welcome back to this educational activity that focuses on stroke risk reduction in people with diabetes. I'm Silvio Inzucchi. I'm an endocrinologist at Yale University, and I'm joined by my colleagues, Dr. Karen Furie, who's professor of neurology at Brown University and chief of neurology at Rhode Island Hospital, and Dr. Alice Cheng, an endocrinologist at the University of Toronto. Karen and Alice, welcome back.
Thank you.
Thank you.
So Karen, we just heard your presentation, why focus on stroke in people with type 2 diabetes? And I had a couple questions for you. The first is, it's always been very curious to me that the major metabolic defect, obviously in diabetes, is hyperglycemia. Yet older studies that have tried to control hyperglycemia have been essentially neutral for cardiovascular disease endpoints, and specifically stroke. So correcting the major metabolic defect doesn't have a significant impact on the major complication of this disease, which is macrovascular disease. So I just want to pick your brain, your thoughts on that. Why might that be?
Silvio, you bring up a really important point. By the time patients present with symptomatic cerebrovascular disease, they've already been living with diabetes for years or decades. As a result, they've withstood the cumulative effect of vascular injury over that entire time. After a person presents with stroke, it may be the too little, too late phenomenon that correcting blood sugar at that point in time is not sufficient to reverse the effects on vascular endothelium and on the hemostatic system. In addition, it's really important to recognize that stroke has multiple mechanisms. And so you have other conditions like atrial fibrillation or hypertension that may be conveying significant risk. And while that doesn't make them more important than diabetes, it does dilute the effect, the impact of diabetes. And these situations are not isolated. In fact, they're occurring in parallel because diabetes is not only contributing to atherogenesis of the extracranial and intracranial vessels, it's also affecting cardiac vessels, and it's causing cardiomyopathy and atrial fibrillation and contributing to risk of stroke. So I think we have to be more sophisticated in terms of how we think about managing diabetes earlier. Particularly in the pre-diabetic or insulin-resistant state. And we also need to think about multi-risk factor modification and not focusing on one single etiology.
Great, that's really interesting. I mean, your points about pre-diabetes are really important, and we don't have the trial data yet, but we don't know if controlling glucose earlier on in the disease course might improve outcomes. The IRIS trial with pioglitazone suggests that, but that was a different type of study looking at insulin resistance. Alice, your thoughts on this really important question of glucose control, and not just stroke, but all cardiovascular endpoints, older drugs versus newer ones.
Yeah, I think that's always made us a little bit sad, if we were to be honest, as endocrinologists, that the glucose control studies we're not hitting it out of the park, right? In terms of all complications melt away as soon as you fix sugars. It's clearly not the case. And I completely agree with what Karen has said. Diabetes is not just sugars. I think that's how we originally defined diabetes, specifically type 2 diabetes, but we now understand that it's a far more complex metabolic disorder. And I think time is the most important factor, because when we do look at the studies of intensive glucose control, and I don't even like calling them intensive glucose control, I'd say maybe more appropriate glucose control studies, the earlier one intervenes and then the longer one is able to keep it, then we do in fact see some cardiovascular outcome reductions when it's implemented early, and it takes a long time to be able to show those benefits. So I think it really drives home the idea of early investment in health. And by the time someone's diagnosed with type 2 diabetes, there's already been a lot of metabolic impact. So if we wait even longer, then I think, we've missed the opportunity to intervene. So glucose control does still matter, but on its own, it's not effective. And I think if we implement it very early, then we have hope of being able to impact those larger complications.
Right. And there's also a strong microvascular benefit that we can't
Absolutely,
forget
yeah.
about. So as long as we're on the topic of glucose and stroke, Karen, a number of years ago, there were at least 2 trials, I believe, that looked at acute glucose management during stroke, in other words, with IV insulin. But those studies, I recall, were neutral, correct?
That's right. And in fact, Silvio, what they demonstrated was that there's a greater risk of causing hypoglycemia. And particularly in the setting of acute stroke, that may have very deleterious effects. It may cause worsening of neurological deficits and impair recovery. So the field has sort of moved away from very aggressive, intensive management. Patients who are admitted to the hospital are usually put on a sliding scale to keep them euglycemic. But there isn't really a move to try and aggressively get the blood sugars down. And typically we work with internal medicine and endocrinology to bridge the period between the acute hospitalization and return to the community, because often there will have to be adjustments made in the diabetic regimen.
One more question for you, Karen. You're obviously a neurologist. What is the role of the neurologist in terms of post-stroke cardiovascular risk reduction?
So the event, the acute stroke, is an opportunity to educate and to inspire patients to become more involved in the management of their vascular risk factors, including glycemic control and diabetes and multiple risk factor modification. So oftentimes it is the opportunity to discuss things like weight loss, physical activity, diet. It's an opportunity to discuss antithrombotic regimens that might become permanent over time. The neurologist is also looking at the mechanism of stroke. So it may be, for instance, in someone with atrial fibrillation, that their diabetes regimen needs some modification based on the hemoglobin A1C measured upon admission. But that person may also need to start on an oral anticoagulant. And so again, you're factoring in not only the primary risk factors, but some of the secondary systemic effects that may have contributed to stroke.
I think we all need to work together, primary care physicians, neurologists, cardiologists, and endocrinologists, to make sure that our patients are getting the optimal CV risk reduction after their initial stroke events.
Absolutely.
Karen Furie, Alice Cheng, thanks so much for joining me in this discussion today.
Thank you.
Thank you.